So TDLR, I didn't feel like watching your whole video. That's fine. Negative and neutral, you have to flush, 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 and then clamp before removing. Positive displacement, you have to flush, 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 remove, and then clamp. And then anti-reflux, it doesn't matter. You can flush, 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 then clamp, or remove and then clamp. Anti-reflux doesn't matter what part of the sequence you clamp, as long as you clamp before you walk away. But positive requires you to clamp after removal. Neutral and negative requires you to clamp before removal. All right, so we have positive displacement, needleless connectors here, and the anti-reflux, and we're gonna compare to see what the difference looks like. We'll do the negative. So this is a negative displacement. These two are positive displacement. This is anti-reflux. Let's see what the differences look like. Flush, flush, flush. Okay, good amount. And then we're gonna disconnect. And then we're gonna see how much is refluxed. So this is how much is refluxed into the catheter. And this is why it's important to clamp sequence properly. You have to have the right clamping sequence. Let me show you what that looks like. Best clamping sequence is to flush, clamp, and then remove. And look at that, minimal reflux. You can see a little bit at that tip, but pretty significant difference between the whole catheter and just that little bit. Now let's do the positive displacement. We're gonna flush, flush, flush. Okay, clear out that line, and then disconnect, and let's see what happens. I'm sure you saw that. Pretty good. Okay, let's try it again. Did you see that? I'll show you that later. Flush, flush, flush the line. And then we're going to remove, and then you should be clamping. You should be clamping after removal for these positive displacement. Not bad, but here's what happens when you actually connect it. So let's say, oops. Let's say we flush a line. The medication was running. We disconnected it, okay? We took off the medication, the IV tubing, and now we're ready to flush. Or we flushed the line, okay? And now we're ready to connect the med tubing. It requires, all positive displacement requires an influx, a pressurized influx of fluid to push out the rest of the catheter cavity. So you really want to make sure that you flush it, use it as quickly as possible, because you're always going to get a little bit of reflux, and then remove, and then clamp. Okay, now let's try it with this one. See if this positive displacement is any different. Oops. So this is full of air right now because it's fresh, so I'm going to flush this line. You can see that air bubble. There we go, coming out. So we flush, 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 make sure it's cleared, okay? And then we remove. Let's see how much refluxed. Pretty good. And then you want to clamp afterwards. So positive displacement, flushing and clamping sequence is flush, remove, then clamp. You do not want to clamp before. I was actually incorrect last time. I said that you want to clamp before removing all of them, and that's not true. With positive displacement, you have to flush, then remove, oops, right? And then clamp it off. Now let's see if it refluxes blood on connection. Okay, so again, positive displacement requires, interesting, it requires the fluid pathway to suck in, and look at how much it's, there we go, could have been because I elevated it, but it requires volume of fluid to get sucked in to push it out on disconnection. Watch, it's really cool. Say flush, 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 well, it's pulled in air, okay? So it requires that negative pressure, that reflux, to push out the rest of the fluid on disconnection. This is how they're preventing the blood from fully staying in the catheter. But you know, the question is, like, does it matter how many seconds blood is actually in that catheter? So proteins adhere to polyurethane immediately on contact. Now, how much it gets layered on, so there is a time factor to how long. So how long the blood is exposed to the inside of the tubing in the catheter. So I would say the longer we have the tubing connected like this, the longer you're having protein exposed to the polyurethane or whatever the catheter material or the tubing material. So you really want to flush immediately. You don't want to have it connected there and sit there for a while, or have the medication tubing connected and then sit there for a while before you start the medication, or else that clotting is going to start happening pretty quickly. So with these, you want to flush or start the medication as soon as possible, or else that reflux of blood is going to sit there for a while. And then remove to spit that fluid out, and then you want to clamp. You don't want to flush, clamp, and then remove the syringe or the medication port or the tubing, because the amount of negative pressure that's still retained after clamping is going to cause the plunger or the needleless connector septum to stay open, which is going to increase your infection risk and contamination for that site, and it won't close all the way. So it's going to allow things to go in. So you really need to make sure that you follow the instructions and clamp after removing the positive displacement syringes and medication from positive displacement. So these are positive displacement. This is negative displacement. They all make a difference. They are not anti-reflux. There's only two anti-reflux. I believe it's the neutron and the TKOs that were classified as anti-reflux, but double check your IFUs to make sure, like, read it. Don't go off of what other people say, because I didn't know there was a difference until I actually read the documentation. So read the documentation. Again, vet it for yourself and make sure you're using it properly. These two, I believe, are classified as neutral. Flush this out. So let's go ahead and disconnect. See if there's much going on there. Not bad, but still a good amount of reflux. I mean, that's enough clotting to, let's see if that does anything. Yeah. So there's about half a cath. So this is what, 4.5 centimeter. So half of that, so about 1.25 centimeters worth of catheter is refluxed. Let's see if there's any movement. So these you want to clamp before removal, clamp and then remove them, okay, to prevent that reflux. Now there's a tiny bit, but because of the fluctuations in your vascular system and the movement of the catheter, the movement of the body, the bending of the catheter, all that makes a big, even the bending of the J-loop all causes reflux. The devices won't completely eliminate natural refluxing. What I'm trying to show is the amount and the differences between all the different connectors, because we need to know how to properly use them. If you're using them right, it's going to turn out well for the patient, but if we're using them wrong, that's the issue. So you have to know which one you have and how to use them. That's the whole point of you testing all this out yourself. All right, so let's see if there's going to be any reflux when I on connection here. Yeah, a little bit. So these are neutral. Okay, let's check out this one. I'm gonna flush, flush, flush. Clear that line. There we go. So we know that the flushing clears it pretty well. Okay, I'm gonna disconnect. Oops. Just flush, flush, flush. Disconnect. So this neutral one is not very neutral. So there's all that reflux happening there. Let's see what happens on connection. Not really much of a difference. So it is kind of neutral, more a little negative-y. Lisa Gorski and Nancy Moreau did a really fantastic job breaking down a lot of these different connectors and talking about how some of the claims don't line up with what is actually happening. Not my words. These are words from the study that Lisa and Nancy Moreau did. So I highly recommend you to go check it out. I'll put a link out there. It's really interesting stuff, actually, to see what's happening under the skin compared to what's happening, what they're saying is actually happening. So this is the anti-reflux. Again, I am a consultant. I am biased. So please examine what I do with extreme skepticism. And please let me know in the comment, is there any way I could have done this test or simulation any better? So we're going to flush the line. Okay, clear the line of air. Okay, and so let's see. All right, line is clear. Flush it back out, then disconnect. Let's see, pretty good. No reflux on removal, and then let's see what it looks like upon connection. Again, pretty good. So this is the true anti-reflux. I wish I had the neutron to compare it with, but I don't have any on me. If you guys want to send me a neutron, I'd love to test it out. You can test it out for yourself. But from what I understand, the classification of the neutron and the TKOs are the only two anti-reflux. Please put in the comments, correct me if I'm wrong. If there is another anti-reflux device out there or needleless connector, let me know. I'd love to read up on it. In my opinion, again, I'm biased, the anti-reflux is the way to go. Because I cannot train every single nurse to do it right. I cannot train every patient to do it right every time. We're talking about home patients here, which I think is a big deal, because yeah, we may be able to train our nurses on this and they might care more. I don't know if the patients are going to get all this. So this is just as important for patients as it is for nurses. The issue is I can't show this video to everybody. I can't evaluate every single different device that's out there in the market that's at that particular hospital or for that home health agency. And so I'm hoping this demo will help you guys understand that there are different types that do very different things, and we need to pay attention to it because the lines are going bad quickly because we're not doing the right thing. We have to read the IFUs and follow the IFUs. And so, yeah, if you know of any other anti-reflux, please let me know. The reason why I like and prefer the anti-reflux, again, I'm biased, is that I don't have to keep going in and reteaching my patients on the proper technique of flush sequence and clamping sequence. Literally, whether I remove it first, and clamp or clamp before removal, the anti-reflux mechanism makes it not matter. So I just tell them, hey, after flushing, go ahead and clamp whenever. That way it mitigates that human error of did the nurse clamp first or remove first. So it kind of eliminates that variable and keeps it consistently not refluxing the catheter. We don't care as much, I don't think, because we can't see it. When we can see it refluxing, even when we do see it refluxing into the hub, when I was in the ED, I didn't care because it wasn't my problem when they went up with the clotted line, because they would go up anyways and they would have to replace it anyways. So, you know, a lot of it was my fault. A lot of it is our fault in these getting clotted off. But because a lot of times we can't see what's happening underneath, you know, we don't know the consequences of these multiple sticks. And so I think it's important for us to be aware of what the proper technique is to minimize the amount of reflux inside the catheter, so we don't let it go bad, clot it off, and then of course have to restick the patient. So that's the ultimate goal. I don't care what device you use, just know what device you're using, how you're supposed to use it.